Bismillahirrahmanirrahim. Assalamu alaikum. Today we shall learn how to keep cirrhotic patients alive without liver transplant. In the scenario where transplant is not accessible and we need focus on survival strategies. Cirrhosis is a chronic, progressive, irreversible liver disease. In many parts of the world, liver transplantation is the definitive treatment. However, in our region, transplant access is limited, late referrals are common, costs are high, donors are scarce, and most patients are not suitable candidates. The major clinical question we face daily is, how do we keep cirrhotic patients alive when liver transplant is not an option? Today's lecture focuses on the practical, evidence-based, real-world approach to cirrhosis management. How to prevent decompensation, how to manage complications aggressively, how to reduce hospitalizations and mortality, how to improve quality of life, how to delay progression, and how to maintain survival. We will follow clinical scenarios to explore ascites, spontaneous bacterial peritonitis, variceal bleeding, hepatic encephalopathy, renal dysfunction and HRS, nutrition, sarcopenia, frailty. Then we will discuss role of beta blockers, lactulose, rifaximin and albumin, and we shall touch upon vaccination, surveillance, and prophylactic strategies. The goal is not to cure, but to stabilize, prevent decline, and prolong survival through systematic, protocolized care. Bismillah ar-Rahman ar-Rahim. Greetings from my institute, Life Care Hospital and Research Institute, Peshawar. Topic for today's discussion is how to keep cirrhotic patients alive without liver transplant. Why this topic matters? We know majority of cirrhotics globally never receive transplant. Mortality in cirrhotic patients is mainly from preventable complications. Different complications like hepatic encephalopathy, variceal bleed, ascites, and tumor, they can be prevented or treated in the early stage. So we can prolong survival with protocols. If we know the protocols, if we follow the protocols, we can prolong survival of cirrhotic patients without liver transplant. Learning objectives of today's lecture. This lecture focuses on the practical, evidence-based, real-world approach to cirrhosis management. And it will cover how to prevent decompensation, how to manage complications aggressively, how to reduce hospitalization and mortality, how to improve quality of life, and how to delay progression of the disease. and how to maintain survival without liver transplant. The roadmap for today's lecture: we will follow clinical scenarios to explore ascites, spontaneous bacterial peritonitis, variceal bleeding, hepatic encephalopathy, renal dysfunctions and hepatorenal syndrome, nutrition, sarcopenia and frailty, role of beta blockers, lactulose, rifaximin, and albumin in cirrhotic patients. And what about vaccination, surveillance, and prophylaxis? So we will cover all these topics in today's lecture, inshallah. But as usual, before starting our lecture, a pre-test for you. I'll request to please note down the questions. I'll share with you the suggested or the possible options, answers, and you will select the one which you think is the right one. And after the MCQs I'll share with you the key or the correct answers, and you will mark yourself. Then we will have a lecture, and after the lecture, we'll again have the clinical MCQs as a post test, and then you can compare that how was today's lecture performance. So the first pre-test MCQ is: which of the following best predicts 1 year survival in cirrhosis? And the option is A, Child-Pugh score, option B, MELD score, option C, serum albumin alone, option D, platelet count, and option E, sodium level alone. So whichever answer you think is correct, please write down the question number 1 and then write down the correct answer which you think is the right one. Moving to question number 2, it is: in cirrhosis with refractory ascites, cirrhotic patients with refractory ascites, long-term survival is improved by A, repeated paracentesis alone, option B, tips in selected patients, option C, diuretics escalation, option D, fluid restriction, and option E, routine antibiotics. So please, against the question number 2, write down the option A, B, C, D, or E, which you think is correct. Moving to question number 3, which of the following reduces mortality in spontaneous bacterial peritonitis? Which of the following reduces mortality in spontaneous bacterial peritonitis? Option A, IV albumin. Option B, repeat paracentesis. Option C, high dose furosemide. Option D, octreotide. And option E, vitamin K. Again, please write down the correct answer which you think is the correct one against the question number 3. Moving to question number 4, long-term non-selective beta blocker therapy is contraindicated in option A, compensated cirrhosis, option B, large varices, option C, recurrent variceal bleeding, option D, SBP with hypotension, and option E, pre-transplant evaluation. Against question 4, please write down the option which you think is the correct one. Well, going to question number 5. The strongest predictor of mortality in acute variceal bleeding is option A, size of varices, option B, Child-Pugh class, option C, presence of red veil sign, option D, time to endoscopy, and option E, portal vein diameter. Please write the option which you think is correct in front of question number 5. Moving to question number 6, which intervention prolongs survival in cirrhosis with recurrent hepatic encephalopathy? Option A, zinc alone. Option B, rifaximin and lactulose. Option C, repeated enemas. Option D, tips for all. And option E, high protein restriction. Please write the option which you think is correct against question number 6. Well, moving to question number 7. Best management for hepatorenal syndrome type 1 is option A, IV fluids plus diuretics. Option B, terlipressin plus albumin. Option C, dopamine infusion. Option D, paracentesis. And option E, antibiotics alone. Please write down the option which you think is correct against question number 7. Moving to question number 8. In compensated cirrhosis, the most effective strategy to prevent decompensation is option A, salt restriction. Option B, non-selective beta blocker therapy. Option C, vitamin E. Option D, paracentesis. And option E, routine rifaximin. Please write down the option which you think is correct for question number 8. Okay, question number 9. Which vaccination significantly improves outcome in cirrhosis? Influenza only, pneumococcal only, hepatitis A and B, meningococcal, and Tdap. Of course, for this, patient should not be hepatitis B related liver cirrhosis. So, please note down the answer which you think is correct for question number 9. Now the 10th and the last question. Best marker for sarcopenia in cirrhosis. Option A, serum creatinine. Option B, BMI. Option C, CT scan, muscle index. Option D, albumin. And option E, hand grip alone. Please note down and write the option, the answer, which you think is correct for question number 10. Okay, now I'll share with you the answers of the MCQs, and you compare your answers with this and mark yourself 1 mark for each answer, that how many marks have you got in this pre-test MCQs. So for MCQ number 1, correct answer B. MCQ 2, correct answer B. MCQ 3, correct answer is A. MCQ 4, correct answer D. MCQ 5, correct answer B. MCQ 6, correct answer B. MCQ 7, correct answer B. MCQ 8, again correct answer B. MCQ 9, answer C was the correct one, and for 10 also answer C was the correct one. So please you compare your answers with this key and give marks to yourself accordingly. There is no negative marking. Okay, this is a normal liver, and this is when liver becomes cirrhotic. So now let's see the journey, how the liver becomes cirrhotic, or what's the difference between a normal liver and a cirrhotic liver. Normal liver shown here in green and cirrhotic liver shown here in blue. So no cirrhosis and cirrhosis. Let's see what's the difference between a patient's chronic liver disease patients with no cirrhosis or without cirrhosis and chronic liver disease patient with cirrhosis. The cirrhosis we can further divide into compensated cirrhosis, the yellow one, and the decompensated cirrhosis. So a chronic liver disease patient may fall in non-cirrhotic category or cirrhotic category, and this may be a compensated cirrhosis or decompensated cirrhosis. We further divide the compensated cirrhosis into two categories. In the first, there are no varices and no ascites. And the second stage of the compensated cirrhosis, varices appear, but there is no ascites. While in decompensated cirrhosis, we see the variceal bleeding and our ascites. So depending upon the varices and ascites, the compensated cirrhosis has two stages. The first stage or the initial stage, when there are no varices and no ascites, and in the second stage, varices, they appear, but they have not bled yet. And again, there is no ascites. If the varices, they bleed, and there is no ascites, this is decompensated cirrhosis. And the varices may be there, but no bleeding, and the ascites appear, then again, this becomes decompensated cirrhosis. So this is the difference between compensated and decompensated cirrhosis. In decompensated cirrhosis, patient either present with GI bleeding, hematemesis melena, or the patient present with ascites. But if there is no history of variceal bleeding or ascites, the patient is in compensated cirrhotic stage. When you do the endoscopy and there are no varices, the patient is in first stage of compensated cirrhosis or the initial stage of compensated cirrhosis. And when the varices are there on endoscopy, then this is the second stage of compensated cirrhosis. But once these varices bleed, he is shifted to, or he enters the decompensated cirrhosis, or varices are there but ascites develop, again he becomes a decompensated cirrhosis. Remember, this lecture is available on my YouTube channel. You can search against the name of Professor Javed Iqbal FAROOQI and you will get my YouTube channel, Medicine Made Easy, and this lecture is available on that channel. Okay, we proceed ahead. What about the complications, hepatic encephalopathy? The hepatic encephalopathy may appear, or the patient may present, the chronic liver disease patient may present in hepatic encephalopathy in any stage. When a patient is in decompensated cirrhosis, the patient is either GI bleeding or the patient has developed ascites. Here, if the patient develops hepatic encephalopathy, this is a consequence of liver cirrhosis. But if the patient has not GI bleeding or no history of GI bleeding, no ascites, and the patient presents with hepatic encephalopathy, this is because of the acute and chronic liver failure. The chances of hepatic encephalopathy because of acute and chronic liver failure, it's minimal. With the patient has got no cirrhosis, but just the chronic liver disease. And this is moderate here, and this is higher here. But remember that appearance of hepatic encephalopathy does not mean the patient is decompensated. For decompensation, you need another symptom that may be variceal bleeding or ascites. But if there is no variceal bleeding and no ascites, and there is not at the presentation and not before, then this is acute and chronic liver failure. Then the another compensation, the hepatic cellular carcinoma, the liver cancer. The chances of liver cancer are highest when the patient is in decompensated cirrhosis. They are moderate in compensated cirrhosis, and it's minimal when patient is chronic liver disease and not cirrhotic. But patients with chronic hepatitis B and fatty liver, they may develop hepatic cancer without becoming cirrhotic. We go ahead and let's dig deeper. What's the basic difference between non-cirrhotics and cirrhotics? This is the portal pressure. In non-cirrhotic, the portal pressure is normal. While in cirrhosis, the portal pressure is increased and the patient is having portal hypertension. So the hemodynamic difference between the between the cirrhosis and no cirrhosis is portal pressure. In the absence of cirrhosis, portal pressure will be normal. But once the patient becomes cirrhotic, in all the decompensated and decompensated, patient has got portal hypertension. Now let's see this portal pressure measure in detail. We divide the portal hypertension into two stages, insignificant and clinically significant. The portal hypertension in the first stage of the cirrhosis is insignificant, while in the second stage of compensated cirrhosis and the decompensated cirrhosis, the portal hypertension is clinically significant. Here it's clinically insignificant, here is clinically significant. And what do we mean by this? What are the values? In the absence of cirrhosis, the hepatic venous pressure gradient is 5 or less than 5 millimeter. While in cirrhosis, it is above 5, 6 or above. And then we divide this when it is between 6 to 10. This is called insignificant portal hypertension. And this is in the first stage of the compensated cirrhosis. Studies have confirmed this. While in the second stage of the compensated cirrhosis, it is between 11 to 12. And when the pressure rises about 10 till 12, the varices develop. And when it is about 12, this is the time when the varices burst, bleed, the ascites worsens. So this is the whole pathophysiology of a patient with chronic liver disease, initially non-cirrhotic, then cirrhotic. Okay, we divide the chronic liver disease patients into 4 stages. The green stage, the non-cirrhotic chronic liver disease. Then the compensated cirrhosis, I told you the color coding. Then the decompensated liver cirrhosis, which is the red one. And then the end stage liver cirrhosis. So these are the 4 stages, and you see these are the progressive ones. Once the patient becomes cirrhotic, the patient has the natural courses, patient will progress from one stage to another and then another. So in the non-cirrhotic chronic liver disease stage, patient is chronic liver disease, but it's non-cirrhotic stage, the patient has normal lifespan. There is normal quality of life. It's asymptomatic phase, and liver transplant is almost not required. It is required only when these patients develops acute and chronic liver failure. In the compensated liver cirrhosis, the median survival is 12 years. This is the stage when the patient has no ascites at all, and the patient may be having varices or no varices, but they haven't bled. So the median survival in this stage is 12 years. Quality of life is good. It's asymptomatic phase again. The HCC may appear. Here also the HCC may appear, but the chances is less. And liver transplant may be required for HCC or for acute and chronic liver failure. When a patient progresses from compensated liver cirrhosis to decompensated cirrhosis because of either variceal bleeding or because of the liver cirrhosis, ascites, what happens? The median survival drops to 2 years, from 12 years to 2 years. The quality of life is poor now. The patient either develops ascites or the patient varices the bleed. The patient may be having episodic hepatic encephalopathy. Jaundice may appear, and HCC chances are high, and the patient needs liver transplant for these indications are for HCC. In the end stage liver cirrhosis, the median survival, which was normal in non-cirrhotic chronic liver disease, it was 12 years in compensated cirrhosis, and it was 2 years in decompensated cirrhosis. It's dropped now to 2 months. The quality of life, which was normal in non-cirrhotic stage, it was good in compensated cirrhosis. It was poor in decompensated cirrhosis. It's miserable now. And what happens? The ascites becomes refractory or spontaneous bacterial peritonitis. If a patient is present with GI bleeding, the variceal bleeding, now it's uncontrolled or there are rebleeding episodes. The hepatic encephalopathy, which was episodic here it's become persistent hepatic encephalopathy, then acute and chronic liver failure. If it is developed here, it is pushed the patient into terminal stage. The bacterial infections are common here. AKI with or without HRS is common here. There may be adrenal failure, hepatopulmonary syndrome, portal hypertension, pulmonary portal hypertension, the cirrhotic cardiomyopathy, coagulopathy, malnutrition, hepatic hydrothorax, empyema, hyponatremia, where the sodium is the fatally low, less than 130 HCC, and liver transplant is required definitely in this stage. So these are the different stages from which the patient progresses from one stage to another, and then to the terminal stage. This is very important. This is the natural course with liver cirrhosis. Patient diagnosis, and as I said, that it's a normal lifespan here. Then Almost 10 years are passed here. And when the patient develops decompensated cirrhosis, only 2 years of life are left now. And here when the patient becomes terminal, then almost 2 months of the 13th year, it is left now. So this is how the mortality it increases till the compensated liver cirrhosis around 10 years lifespan is there. When the patient becomes decompensated, then 11 and 12 years, only 2 years median survival. And when the patient is terminal, only 2 months. This is shown here, the color coding: yellow, red, and black. So the liver transplant is required as the naturally decompensated stage. If the patient has reached here and has developed the decompensation, then this is the stage where liver transplant is required. Our HCC in compensated stage, the patient was here in the yellow, but the patient developed the HCC. Again, the liver transplant is there, and a time is when the patient develops acute or chronic liver failure. So this is the stage of liver transplants, this one. This is the stage when we need liver transplant. So how to keep cirrhotic patients alive without liver transplant? This is we are discussing today. Well, I would like to share with you our study which we presented almost 9 years ago in 25th Apostle, Tokyo. The complications of liver cirrhosis in Pakistan. This is our center data, and around 2,780 patients we included. And the etiology of the liver cirrhosis, 77% of our patients, they were because of hepatitis C. The 22% of patients, they were because of hepatitis B. And only 1% of patients, they were because of the other etiologies. Remember, now the NAFL or the MASL or the fatal liver disease is becoming more and more common as a cause of liver cirrhosis. This is the Child-Pugh class and MELD score of these patients. And regarding the child class, the 53% of the patients, they at the presentation, this is the one time the patient was included once. The same patient was not repeated or not the entered second time. So 53% of the patient, they were in child class A, 36% they were in child class B, and 11% was in child class C. It means in more than 50% of the patients, we could intervene, we can intervene to prolong their survival. Then regarding the MELD score, the less than 10 was in 49% of the patient, 11 to 20, 39% of the patient, and more than 21, 12% of the patients. And this is very important, the complications profile. The most common complication, 44%, we saw ascites. In 29% of the patients, we saw overt hepatic encephalopathy, clinically detectable. In 26% of the patients, they were having varices. In 11% of the patients, they presented with GI bleed. In the 22% of the patients, they presented with coagulopathy, or they was having coagulopathy. In 12% of the patients, they were having HCC. And in 4% of the patients, they were having HRS. And remember that this was not the solo presentation. Patients were having either one complication or two complications or three or any combination. So, but this was the complication profile. These complications may be more than 2, 3, or 4 complications were present in the same patient. But the number of the complications at presentation once recorded were these. So less than 1% could afford liver transplant. This is the important point. So this is very relevant, how to keep cirrhotic patients alive without liver transplant. Historical perspective, in 1980, the care of the cirrhotics was symptomatic only. In 1990s, we were talking mostly about the variceal bending and diuretics. In 2000s, the tips, albumin, and rifaximin were the topics of discussion in the cirrhotic care. In 2010, the prevention of the decompensation paradigms, they were published and they were discussed and they were the hot topics. The major causes of mortality in cirrhotic patients, we know this is the variceal bleeding, SBP or sepsis, hepatic encephalopathy, HRS or renal failure, frailty and sarcopenia, and hepatocellular carcinoma. So the first clinical scenario which I would like to share with you, a patient with recurrent ascites. 58-year-old male, recurrent tense ascites despite diuretics. Key interventions which we should do here is sodium restriction, spironolactone and furosemide, and we increase the dose of furosemide to 160 milligram and spironolactone to 400 milligram unless it is intractable ascites and patient cannot tolerate this and they develop the complications. Then large volume paracentesis is the answer in such scenario. Albumin 8 gram per liter taped, we should be giving that, replacing that. This is very important. Without the albumin cover, the patient go into hepatic encephalopathy, hepatorenal syndrome, and they die. So this is very important. You do the large volume paracentesis under the cover of the albumin. Refractory ascites, the options which we have. Tips, if patient is a child class B and there is no encephalopathy, you consider tips. Long-term albumin therapy, regular albumin therapy is another option. Coming to a clinical scenario, spontaneous bacterial peritonitis. Patients presenting with ascites, fever, confusion, with the polymorphs, neutrophils, the more than 250. Treatment here, we know it's the third generation cephalosporin, IV albumin. On the day 1, we give 1.5 gram per kg. Then on the day 3, we give 1 gram per kg. And we offer the secondary prophylaxis, norfloxacin and ciprofloxacin daily. The third clinical scenario is the variceal bleeding. Patient presenting with hematemesis, hypotension. And the treatment here is resuscitate carefully, the non-selective beta blockers after bleeding controlled, band ligation, terlipressin, all these are the options. Then the clinical scenario, the patient may present with hepatic encephalopathy. And we know the patient presents with confusion, constipation. And the treatment we offer is the lactulose to 3 to 4 stools per day, rifaximin if it's the current episodes of hepatic encephalopathy. We need to correct the electrolytes, stop the sedatives, and of course treat the precipitating cause. Then the fifth scenario, the hepatorenal syndrome, when a cirrhotic patient presents with increasing creatinine and oliguria, and we treat this patient with terlipressin and albumin, we stop the diuretics, we exclude hypovolemia. Patient may present with nutrition, malnutrition, and sarcopenia. The core principles in such scenario is high protein diet, 1.2 to 1.5 gram per kg per day. We should ensure this. Late night snacks are important. Resistance exercises are very important. Then vaccination and prevention. Again, this is important. Essential vaccinations include hepatitis A and B, the influenza, the pneumococcal vaccine. Surveillance. This is again very important point in the cirrhotic patients. HCC screening is very important. We do the ultrasound alpha fetoprotein every 6 months. So putting it all together, every cirrhotic patient should be on non-selective beta blocker, lactulose. The patient should receive vaccine, and the screen the hepatocellular for the hepatocellular carcinoma is very, very important. And of course, we should look after the nutrition and the exercise, and we should prevent the infections. So cirrhotic patients, they are very delicate creatures. And there are many challenges, and we need to correct those challenges, those abnormalities. So how to keep cirrhotic patients alive without liver transplant? We need to optimize medical management, nutritional support, lifestyle modifications, psychological and social support, palliative and supportive care, manage comorbidities, physical activity we should ensure, and of course, frequent follow-up and multidisciplinary care. Let's briefly discuss these options in some detail. First, the optimized medical management. We should control the complications in time if the patient presents with ascites, low sodium diet, diuretics, spironolactone, furosemide, therapeutic paracentesis, albumin use. All these I have discussed with you. We should consider tips in selected patients. If a patient presents with hepatic encephalopathy, lactulose and rifloximine to reduce ammonia is very, very important. Protein intake should not be overly restricted, which is the most common mistake people are doing. Of course, we should address precipitating factors. Then, if the patient is presented with variceal bleeding, so screening and prophylaxis with non-selective beta blocker, vein ligation, we should not forget secondary prevention strategies. They are very, very important. Patients presenting with infections, high risk of SBP and sepsis is there in cirrhotic patients. Early detection and antibiotic prophylaxis for spontaneous bacterial peritonitis is the key to success. Regular monitoring is very important in these patients. Frequent labs, liver function tests, renal functions, electrolytes, imaging, the ultrasound with Doppler every 6 months for hepatocellular carcinoma. Surveillance is very, very important. And of course, endoscopy periodic for variceal screening and management. Then the nutritional support. We should address sarcopenia and malnutrition, which is seen in more than 60% of the cases. Liberalized protein intake, 1.2 to 1.5 gram per kg per day. We should avoid protein restriction unless encephalopathy is uncontrolled. And the caloric needs, 30 to 35 kilocalories per kg per day is a high caloric diet we should recommend to those patients. And vitamin supplementation is very important, B complex, vitamin D, and fat-soluble vitamins. Of course, micronutrient supplementation, zinc and selenium are equally important. We should avoid protein restriction unless encephalopathy is uncontrolled. We should give high caloric, high protein diet, especially if sarcopenia or muscle wasting is present. Vitamin and mineral supplementation, especially B complex, vitamin D, zinc, and fat-soluble vitamins. Know the lifestyle modification. This is very important. Absolute alcohol abstinence if alcohol-related liver disease is there. We should avoid hepatotoxic drugs like NSAIDs, certain antibiotics. The vaccinate these patients against hepatitis A, hepatitis B, hepatitis E, influenza, and pneumococci. Then psychological and social support is very important. Chronic liver disease causes significant psychological stress. Psychological counseling or psychiatric care for depression, anxiety, and cognitive issues is required. Support groups and palliative care consultation can greatly enhance coping with symptomatic relief. Then the palliative and supportive care is very, very important. We need to give them symptomatic control for pain, fatigue, pruritus, anorexia, and sleep issues, and these can be managed individually. We should give advanced care planning, clarify the patient goals, values, and preferences, and this is very, very important when to put them on the palliative care. The palliative care teams improve quality of life even in non-terminal phases. Then the management of the comorbidities. The patient has got diabetes, hypertension, renal dysfunction. We need to control and other coexisting conditions that may exacerbate liver dysfunction. Physical activity is very important. Mild to moderate exercise under supervision improves muscle mass and reduce frailty. Tailored exercise programs, for example, walking, resistance bands, help improve physical function. Similarly, exercise, supervised light aerobic resistance training is very important for cirrhotic patients. Note the frequent follow-ups in multidisciplinary care. This is very, very important. You should involve hepatologists, nutritionists, psychologists, and palliative care specialists. The structured follow-up ensures early detection of worsening symptoms or complications. So, dear colleagues, how to keep cirrhotic patients alive without liver transplant? When transplant is not an option, frailty, advanced age, cancer, socioeconomic barriers because of this, our need for parallel planning is there, treatment and comfort. Symptomatic management focus should be on pain, fatigue, pruritus, anorexia, sleep disturbances. We should avoid polypharmacy. We should consider antidepressants and anxiolytics if appropriate. The psychological and social support is very important for depression, anxiety, cognitive decline common. Role of caregiver support, social worker, psychiatric referral is very, very important. Palliative care integration is important. The early integration improves quality of life and reduces hospitalizations. The goals of care discussions in advanced care planning is there. Multidisciplinary and holistic approach is very, very important. I already discussed with you all these. So the bottom line is, when a patient presents with acute event, we need to treat primary decompensations. We need to treat secondary decompensation complication, and we need to prevent tertiary complication. Then the second stage is prevention of future events by giving the secondary prophylaxis for where the complication has happened, and the primary prophylaxis where those have not happened but we need to prevent those. Then the essential components is arrest inflammation and treat etiology, keep the patient in child class A, ensure desirable nutritional status. The prompt and effective control of infection is important. We should avoid hepatotoxic drugs. Surveillance for HCC is important, and vaccination is the key. So the care of cirrhotic patient is a multidisciplinary approach where the cirrhotic patient is in the center and you need the help of hepatologist, endoscopist, interventional radiologist at times, intensivist at times, hepatobiliary surgeon may be needed, and supportive team are required. The cirrhotic patient is multifaceted and it can present in different ways. So important is you treat the primary decompensation or the primary complication with which the patient has come to you. Then you treat the secondary complications which should not happen, and you prevent the tertiary complications that they should not be there. So the take-home message for you will be, you stabilize the patient and prevent decline, use protocols, albumin and non-selective beta blockers save lives, survival without liver transplant is possible. So we had a pre-test, and now coming to the post-test, few MCQs, and I would like that you note down your correct answers or the answers which you think correct, and after showing the questions, I'll be sharing with you the key. So the first post-test MCQ is, long-term albumin therapy is most beneficial in compensated cirrhosis, refractory ascites, acute variceal bleed, and first episode of SBP are only pre-transplant. Please note down the option which you think is correct for this question number 1. Now the question number 2, early tips should be considered in A, child class A patients with small varices, B, child class C with active bleeding, C, child class B with active variceal bleeding and high-risk stigmata, D, spontaneous bacterial peritonitis, E, HRS type 2. Please note down the statement which you think is correct for question number 2. Question number 3. Which treatment improves survival in hepatic encephalopathy? A. High protein restriction. B. Rifaximin add-on to lactulose. C. Zinc alone. D. Albumin infusion alone. And E. L-ornithine. Please write down the statement which you think is correct for this question number 3. Now the question number 4. Which best reduces first decompensation? Diuretics, non-selective beta blocker therapy, lactulose alone, regular paracentesis, low protein diet. Please note down the option which you think is correct for this question number 4. Question number 5. Motility in spontaneous bacterial peritonitis reduces significantly with A. Ceftriaxone alone, B. Albumin infusion, C. Rifaximin, D. Probiotics, and E. Fluid restriction. Please write down the option which you think is correct for this question number 5. Now the question number 6. In variceal bleed, transfusion target hemoglobin should be more than 10, hemoglobin 9 to 10, or increase the hemoglobin from 7 to 8, or 6 to 7, or no transfusion. Please correct the write down the correct answer which you think is there for question number 6. Question number 7. Main mortality predictor in cirrhosis: A. Serum bilirubin, B. Coagulopathy, C. MELD score, D. INR alone, and E. Ascites volume. Please note down the option which you think is correct for this question number 7. Question number 8. Long-term prophylaxis after spontaneous bacterial peritonitis: carbapenem, daily quinolone, weekly metronidazole, IV cephalosporin monthly, or rifaximin alone. Please note down the option which you think is correct for question number 8. The question number 9. Best strategy to prevent sarcopenia: option A. Protein restriction, option B. High carb diet, option C. Resistance training plus high protein, option D. Vitamin supplements, and option E. Total parental nutrition. Please write down the option which you think is the correct for this question number 9. Now the question number 10. Major contraindication to non-selective beta blocker: option A. Ascites, option B. Hepatic encephalopathy, option C. Spontaneous bacterial peritonitis with hypotension, option D. Hepatocellular carcinoma, and option E is thrombocytopenia. Please write down the statement number, the option which you think is correct for this question number 10. So now I'll share with you the answers, and you match this key with the answers which you have wrote down, which you have written for your on your paper, and then you give marks. There is no negative markings, and then you give marks and think that how much improvement have you made. So for MCQ number 1, the correct answer B. MCQ number 2, correct answer C. MCQ number 3, correct answer B. MCQ 4, again, correct answer B. MCQ 5, correct answer is B. MCQ 6, correct answer is C. MCQ 7, correct answer is C. MCQ 8, correct answer is B. MCQ 9, correct answer is C. And MCQ 10, correct answer is C. So with this, we come to the end of today's lecture. Dear colleagues, cirrhosis without transplant is not a hopeless condition. We can extend survival by months and years if we approach it systematically. The key messages are: first, prevent decompensation. This is the new paradigm. Second, non-selective beta blockers, lactulose, rifaximin, albumin, and TIPS are survival tools. Nutrition and sarcopenia management are as important as drug therapy. Albumin is not just a volume expander, it is a survival therapy. And every complication is an opportunity to prevent the next one. Our job is to keep these patients out of hospital, out of ICU, out of bleeding, out of encephalopathy, out of infection, alive without transplant. Thank you for your attention. I welcome questions, discussions, and shared experience from your clinical practice. This lecture is available on my YouTube channel. You can share your questions, discussions, and experience in the comment section under this video. So I'll be more than happy to answer any of your questions and to learn from your experience. Thank you very much.